I'm delighted to hand over to Maren Simpson, the our Chief Executive, who will be chairing and contributing to this meeting this afternoon.
Thank you, Neil. And it's lovely to see you all here today. Just going to put you on gallery view so that I can see faces and a few with video switched off, but also quite a few faces there. So it's really good to be with you and being able to do this session today. So a very warm welcome. I think we have a mix of connectors and there's some VCSE, some Health Watch, and some sort of other roles within integrated care systems. So quite an eclectic mix today. Hopefully we've got all of those among us. I don't think I've seen Rachel on the call. So from SCW. So I was going to offer Rachel a little bit of an intro, but I'll Neil, perhaps you can keep an eye to see if she arrives, and then we can offer her 5 minutes on that. But the purpose for today, the Health Creation Alliance, I'm Maren Simpson, by the way, and I'm Chief Executive of the Health Creation Alliance. And we've been working with with SCW, South Central West, on this Core20PLUS Connector program, initially advising around the expression of interest and the application for this, and running sessions to sort of to be able to advise and input into that. And then we've done some work around development of a national network, which we expect to emerge at some point for connectors. But we're also offering a little bit of support to coaching, mentoring support to 3 integrated care systems. But as part of that, we offered to do this session as well. And it's very much an introduction to health creation. So I expect that you may well have heard the term health creation around. It's growing in sort of interest, people's interest in health creation and what it is, and how to apply it. And we've developed our own kind of framing and framework to help people to work with this and understand how to adopt it and embed it within things that they do. So that's what we're going to be doing today. And hopefully by the end of the 2 hours, you'll not only have heard us speaking, but you'll have heard you'll have had chance together to kind of test some of this out. So I'm going to say a few words at the beginning to introduce Health Creation and our organisation, and then Brian Fisher, Dr. Brian Fisher, who's chair of the Health Creation Alliance, will provide a little bit of an outline of some of the evidence for health creation, and that it improves not just people's health, but also resilience, and it offers protective factors, etc., that help people to prevent people from becoming ill. And then what we'll do is we'll go on to a couple of case studies, and we'll do a little exercise. Then we'll have a comfort break, and then we'll go into breakout rooms. So hopefully there's plenty there to kind of mull this over and to really get a handle on what this is about. So Neil, if you go on to the next slide. So the Health Creation Alliance is the only national cross-sector group, and we're a movement addressing health inequalities through health creation. And we're actually not just cross-sector, but we're a mix of professionals, community leaders, and people with experience of poverty, trauma, and discrimination. So we're a very eclectic mix of people. And many of our members are doing health creation. Others want to learn more about how to do health creation, and it's free to join, which is why Neil suggested that you might like to sign up. And our mission is to increase the number of years people live in good health in every community. So a fairly common aim of several organisations, including ours. But our ambition, and the way that we think that needs to happen, is for health creation to become recognised as equally important as treating ill health is by our NHS, and the prevention of illness. So we think it's a third pillar and that it's not something just the NHS should do. It's many local partners outside, including communities and all sorts of organisations, can play their part in creating health, but it needs to be seen as a key element of everything that we do, and that's why we want it to be seen as business as usual across the whole system. So if you go to the next slide, when we first responded to the Core20PLUS consultation, we said we liked it because it helped the NHS to focus in on certain populations, the Core20 communities, the plus, some of those health inclusion groups, and then the 5 is sort of the clinical element, a little bit less. We didn't like that quite as much. But it does help the NHS at least to think about underserved communities and those with the poorest health outcomes and refocus on that. But what we said it was missing as an approach to address health inequalities was really everything we've been talking about for the last 7 years, which is health creation. So we suggested that they might like to pop health creation into this formula like we have done there. And that's kind of what we're aiming to do through the work that we do on Core20PLUS 5, and many of you will recognise Bola Olabi there as the sort of lead and figurehead for this. So what is health creation? And that's the next slide. Well, it's a process, and health creation is the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their lives and their environments. And when that happens, the health and well-being is enhanced. And so health and well-being is almost a byproduct of gaining that purpose, hope, mastery, and control. And once people have control, they're much less likely to kind of slip out of having control, although that can happen. And so we think this is a process that people need to understand and build into everything that we do. And then just going on to the next slide, we've made this really simple. We've boiled it down to the 3 C's, but there's lots of evidence for this, and Brian will talk about that in a moment. But what we're really saying is that connections is really important, and it's great that this Connector program is all about those connections and creating connections with the community, but building meaningful and constructive connections or contact between people and within communities increases people's confidence, and that can lead to greater control, both individual agency, if you like, but also collective agency. So together, communities can take control, have more agency within, an influence within what happens in their areas, and so it does enable communities to start to influence some of those wider determinants, as well as the innate benefits, health benefits of having that control and feeling confident. People, of course, it's part of this that people need an adequate income, a suitable home, an engaging occupation, and a meaningful future. And all those elements, some of them can be influenced by giving communities more agency, but actually we need to sort of change the way we do the democracy and enable people to have more of a say over those things, whether that's through political routes or local, listening and more participative forms of democracy. So we do think that having a suitable home is absolutely essential and enables people to get to a certain point to be able to create health. So that's just an example of one of those elements. But having control over our lives is proven to enhance health and well-being, and building that resilience, helping people cope with health conditions, disability, aging, that sort of thing. And then for those of you who kind of like the next kind of diagram, which is a little bit of this is taken from a Public Health England document just towards the end before it became OHID, and it's about the psychosocial pathways around health inequalities, and it's partly Public Health England and the UCL Institute for Health Equity, which Professor Marmot is very aligned, very associated with. But if you look at, I don't want you to need to understand all of this, because health inequalities, the drivers and the causes and the solutions that are actually really quite complicated. But in the middle section of this, you've got adverse and protective psychosocial factors. So you've got adverse factors there, and then protective factors towards the bottom. And if you look at some of these, it talks about self-efficacy, talks about resilience, it talks about having control and mastery, just like we've talked about. We didn't, this came out after we'd got our definition. Hopefully they bought into our definition and put it in here, but control and mastery, ability to learn, social skills, that sort of thing. And at the neighborhood level, we've got, social support, the number and quality of relationships, that density, that social capital is really, really important. And it's a very important part of creating well communities and well people within communities. And also, if the next slide is really just to show you as well that, the Health Foundation has also got a slide on family, friends and community and the importance of this. Just a lovely infographic explaining about how important those connections are, and it all starts with the connections and the relationships. So we have developed this into a framework for health creation, and we did this about 6 or 7 years ago now, and it comes from a number of it has a number of roots, the 3 C's does, but we've crafted it into a framework which is nice and simple and can be used, so it's very practical. And that's the 3 C's that I showed you. But communities can create health by themselves, and they do all the time. And many of the connectors that are working through this program have been doing this for a long time, and they've been, probably, they're probably delighted. I know some of them are delighted that the health service, NHS, is starting to take notice of what they've been doing for some time. So health creation is happening all over the place. We're not suggesting that we've invented it or found it. It's happening all over the place. What we're doing is drawing attention to it and enabling that status and profile of all of that to increase, and for people to see, what's so important about it. But professionals can also create the conditions for health creation. And the way we do that is by working as equal partners with local people and focusing on what matters to the local people and to their communities. And that's quite an important thing. So getting the dynamic right between professionals with our professional hats on and communities, with our community hat on, is very important. And the Health Creation Alliance has focused in on that as being what we're, an important aspect of us being involved in Core 20+5 is to help to set up the right dynamics locally, because we think that if you get the right relationships locally, that drives change throughout the system from the ground up, from where health is being created within communities. And ground up transformation of whole systems is actually what we're about. So those 6 features of health creating practices there are things that, if you can build those in to your practices at the front line and at higher levels within organizations, you can start to create the conditions for health to be created within communities. And those 6 things are listening and responding, truth telling, a focus on strengths, what communities can do, not what they can't do, not their deficits, self-organizing, reciprocity, always go to next, although it's not next on the list, which is about the give-get dynamic. I skipped over self-organizing, but that's hugely important. That's the connecting piece within connected communities, and self-organized groups are much more likely to be able to both be well and get and be powerful within and bring a lot to community life. And power shifting goes throughout all of these elements. We're going to be doing a little bit more on this later, so I'm going to I'll wait. I won't say too much more about those at this stage, but just to give you a bit of a picture as to how this might look, and this is one of our members came up with this a few days ago, and I kind of helped add to it, and it apparently works in Holton, so there you go. But if you think of scurvy, an old-fashioned disease perhaps, but if you just think of how you might take a health creating approach to something like scurvy, well, the preventative approach would be tell people to eat more oranges or lemons. You know, go and that's how to prevent, you know, being how to prevent getting scurvy. The health creation approach, however, might be to say, well, you know, how about growing your own olive grove or orange groves, obviously in a warmer climate, but you know, giving them the land perhaps, or selling them the land at low cost, giving them the tools to do that, the seeds, the plants, the little plants, whatever, and perhaps when they started, you know, creating and growing these oranges, perhaps buy some of the surplus ones off them to create a revenue stream, so they're enabled to do more themselves. So that would be a real health creating approach, elements of that. And social prescribing, which, you know, does sometimes get confused with health creation, or people say, well, we do it within social prescribing, and some social prescribing is health creating the way it's done. But actually what we're probably principally doing through social prescribing is showing people where the orange groves are, so they can go and, you know, find a way to do that preventative work themselves. So that's just a little sort of picture. Very quickly, we boiled down, you know, the 3 C's and the 6 features of health creating processes. This is one of our frameworks. We've got other frameworks as well. But what our hypothesis is that these are the active ingredients in a whole lot of different practices. So these are features of practices. They're not practices in themselves. You can embed this into almost anything you do and find ways to build these 6 features into these. And so group consultations, for example, is a version of self-organizing. It's a really good one. And I'm sure you've got your own version of what that might look like. If we go again to the next slide, what we're finding, and this is what our series of events, if you don't know if any of you popped into any of those at the end of October about coming of age, what we did was we're suggesting that health creation actually can be adopted and built into all of those programs, whether it's population health management or these. We've done a report on the NHS England's 5 health inequalities priorities to demonstrate how by taking a health creating approach you can achieve those. The 10 principles working with people and communities are very similar to health creation, etc. So what we're trying to do is build health creation in, and Core20PLUS5, of course, is no exception to this. And so the next slide is about changing systems from the bottom up. Like I said, if we can get the relationships right, understand what creates health in terms of those relationships within communities, and get those relationships right at the front line, and those 6 features are actually all about different aspects of relationship and how that works, how the dynamic works, then what we think and what we're finding is that you can start to work out at different levels what that looks like. And we're working in one system to do exactly this. And health creation becoming a common currency across all of that. So we've got big ambitions, as you can see, to shift everything, and certainly to shift systems from the bottom up. So for those of you in the next slide who have seen the 10 principles for working with people and communities, which is in systems-wide guidance that has been issued by NHS England, there's 10 principles there, which are on the left-hand side. Sorry, you can't quite read those, but they are available to have a look at. We, about 5 months earlier than that, we published our 10 key messages from a whole load of reports that we'd done in the last couple of years. We said these are the 10 key things that we think that integrated care systems need to do. And we found that they weren't dissimilar to the principles, and we got involved to help shape those principles further. So they've got more health creation in them now than they did when they first came out. So we sort of, if you do health creation, you will be achieving those principles, no problem at all. So I'm going to finish there. We are going to be working, by the way, in the new year on a whole set of calls to action for ICSs that emerged from our coming of age series. So watch out for that as well. But I'm going to stop there and hand over to Brian, who's going to give us some of the evidence for health creation.
Hi, good. Thank you so much, Marion. That was very, very clear and very helpful. I'm Brian Fisher. I'm a GP in South East London, and I'm proud to be chair of the Health Creation Alliance. So I have another load of slides to get through to convince you really about the evidence behind what Meron has been saying, so that when you are out in the field or working in your offices, that you can feel very clear that working with communities, building connections between people and giving people as much control, enabling them to take as much control as possible, has a real impact on their health. So roll the slides, please, Neil, and we'll take people through. Okay. Next slide, please. So we are, as the Health Creation Alliance, we're focused on trying to mitigate to some degree the inequalities in the UK. And I'd like to start by just reminding us how bad it is in this country. So the UK is one of the most unequal in Western Europe. For every classroom of 30 kids, 8 of them are in poverty. 15% of adults owe more than they own, which is a shattering statistic. And those are really about income on the whole, but inequalities of wealth are even larger. So 44% of the UK's wealth is owned by 10% of the population, and the richest 1% own 14% of the nation's wealth, and these differences are increasing. So we are in a very seriously unequal society, and the impact of that is what was shown in one of Meron's slides. So the impact of inequality and issues such as racism and poverty eventually impact on people's health through these psychosocial pathways. Next slide, please. So I'd like to go through these 3 C's and try and give you some evidence that shows you how important the 3 C's are, and again, impress on you really that in your work, you can make a difference if you employ these ideas. Next slide, please. So this is Public Health England as was, and they are very clear on the basis of a whole set of evidence that lacking social connections is bad for our mental and physical health, and that loneliness in particular, as I'm sure you're aware, substantially increases the likelihood of premature mortality. So Public Health England are very clear that these things are very important for us. Next slide, please. So far as mental health is concerned, then the contact between people, social networks, and participation have been shown to be protective against dementia in people over 65. And the other element to this is not only does it protect your health, but it also enables people to be more resilient in the face of stress, such as economic stress. And that's why one of the many reasons why it's so important, particularly now. Next slide, please. This is an example of how emotional support and contact between people enables you to live longer after a heart attack. So men and women who had more sources of support, social contacts are not from the statutory sector, live longer, and it's almost certainly because of the links and the contact they have with others. Next, please. So this is quite an important study. This is a meta-analysis, and it looked at many other studies and came to the conclusion that 50% increased likelihood of survival for people with stronger social relationships. And that took into account controlled for things such as smoking, alcohol, BMI, and physical activity. So the authors were pretty clear that it is to do with these stronger social relationships. And so the impact of this is about the same impact as stopping smoking. So it is a very significant health protective factor. Next slide, please. And this is some of the detail of it, and it shows quite clearly the red lines are the importance of the social relationships and how they compare with things like smoking cessation and so on. And you can see that they're very, very significant. So we can say with very great certainty that if in whatever kind of work you do, you are bringing connections between people together, supporting their confidence and helping them to gain control, then you are improving their health, not only their health, but their health, the health of people around them as well. Next, please. And this is the sort of theory behind it, that these stronger and deeper social networks build resilience, they improve mental health, and they enable people to take more control, both individually, so you can make a difference yourself, but also collectively, so a community can take more control together, and that it's possible through community strengthening approaches. So these are things such as community development that will enable these stronger social networks to happen. So the sorts of work that ICSs do, the sort of funding, for instance, for community strengthening approaches of various kinds, such as community development, would make a huge difference to people's health. Next slide, please. So bringing together contact and confidence. Next slide, please. Again, this is Public Health England, who are very clear that building these strengthening communities reduces health inequalities, enables people to say more about their lives and their health, and engage. And it's very important, of course, to engage those most at risk of poor health. All of that is possible. It's been done in lots of different places, and I'm sure there are examples of that in your areas too, because we know it is happening in lots of different places, but it is very patchy, and different places are offering this kind of community strengthening to different degrees. And our claim, our point, as Maren was saying, is that we want this kind of approach to be systematic and to be everywhere across the system. And so ICSs and you in particular can make a difference to making this happen. Next, please. We also know that it's not just about individual health, that in communities that are active and engaged and take more control, there's actually less crime and delinquency. That's been shown in many different studies. And it also means that people are more likely to be able to find work. They are more confident, they have more contacts, and it's actually easier to find jobs and employment if you have those social networks. This is a particular study that was done a long time ago now, and it was essentially a funded community development program in a number of different sites across England. And you can see that there's a substantial increase in people thinking that it's a good place to live, looking after each other, trusting each other, and a sense that they could take more control over their areas themselves. Next, please. Next slide. So we know that control is probably the most important element that we want to encourage. And we know that Marmot is very clear that young people and adults have to take as much control over their lives as possible. And he's very clear that we need healthy and sustainable places and communities. So these are one of his 5 elements of tackling health inequalities. Next, please. And we can see lots of examples of how this plays out in real life. So in Cornwall, an inspirational health visitor called Hazel Stootley worked on an estate brought people together in order to decide the issues that mattered to them and worked together to actually get change. And they worked with police, with housing, with health to make those changes. And there were substantial improvements in housing, education, health, and crime. The Linkage Plus program showed that it made a huge difference to people's health and independence when older people were given as much support as possible to take as much control as they can. And there's a Marmot study from a long time ago where he showed that although there were the levels of stress were pretty equal between those people in lower echelons of the civil service compared to those in the higher echelons, those people in the higher echelons had much better cardiovascular outcomes because they had control over their working lives. So I'm trying to make the case that there's lots of evidence that control is the key aspect of staying healthy. Next, please. Here is data from Wigan. You may have, some of you may be in Wigan, I don't know, but the local authority over many years, it took a long time to do this, changed the way all the employees in the local authority worked so that they offered a much more community strengthening approach. And over time, there were some very significant public health changes. So obviously this is a local authority, it's not an NHS system, but because of this approach to managing and working with communities in a different way, healthy life expectancy improved. And this is comparing it with areas that are very comparable to Wigan: deaths from cancer, alcohol-related hospital admissions, smoking prevalence, suicide rate, all of these things, the data improved in Wigan compared to other areas. And it's almost certain that it was this different way of working that made the impact. Next, please. So I'm sorry to gallop through these, but there is a lot of evidence about this, and I'm only picking bits of it. So I'm doing a literature search, a literature review for NHS England about community strengthening. And I have found across the world many different examples of fantastic schemes. And there really is serious evidence that if you structure these initiatives correctly, you can make a huge difference to areas. So as I've mentioned, you can make a difference to housing, to crime, to economic development. You can make a difference to preserving services, neighborhood services that might be under threat. I've just been interviewed by someone about events that happened in my part of the world, Lewisham, 10 years ago, where we saved an A&E through enormous community involvement. People have changed tax laws, alcohol laws. So there are examples of where bringing the community together has not only had an impact on individual health, on community health, but on the social determinants of health as well. And this is a very powerful set of possibilities, and we can all play a part in making these happen. Next, please. This is a slide from Jenny Poppe, who's a sociologist, to show that studies suggest that you get better service outcomes, better social outcomes, and better health outcomes the more control is offered and enabled for local people, or taken by local people. And the statutory sector, local authorities, health, housing, police, all have a part to play in working together to enable this kind of process to happen. It's very different to the way the NHS works, which is why we think an organization like the Health Creation Alliance is very important to make these points and to support places to shift in this way. Next, please. So this is the message. Communities taking back control improves health. And the next slide is that for those of you who are connectors, you are in prime position to enable this to happen. And I know there are lots of other people on this call, but you also have the opportunity of making a difference in this kind of way. So if, we are happy in the Alliance to talk through ways of doing this that would make a difference, because we can draw on lots of experience across the country and over time and across the world that can pitch in and help people make a difference. Next, please. So there is some evidence about cost benefit too. You obviously have to spend money on perhaps community development workers or other approaches that may help to make this different, to improve it. And next slide, please. The studies are quite difficult to do, but there is increasing data now that we have. So in Somerset, there's been an extensive set of community connectors. You may know about this before the Core20PLUS and you can see that over time, emergency admissions did reduce compared to the rest of Somerset. It's an extensive piece of work across in a single town, but it has had an impact. Next, please. So we have various studies, and roughly.
Brian, I think we've just lost your audio slightly.
Oh, okay. Shall I shout a bit louder?
Oh, that's it. It kind of, yeah, that's much better. Thank you.
It does come and go. I know that. I have no idea when it's happening.
Yeah,
so
that's
I'll
great.
shout a bit and hope that works. So roughly speaking, for every pound that you invest in community strengthening, you get something like £2 to £4 back in social return on investment. And this has been shown in a number of different places, a number of different parts of the world. And it's roughly that. The Beacon project, which is the one in Cornwall, has a fantastic cost benefit ratio of 1 in 8, but that's pretty unusual. Most of the studies are more modest than that. But we can feel confident that this is something that's definitely worth investing in. So the connectors, you are being invested in, and you can be pretty sure that if you operate in this kind of way, you will be benefiting your local system. Next, please. There are other studies which suggest overnight hospital stays reduced when older people were given much more control and supported to live the lives that they wanted to live. And Nesta, which is a large national organization, looked at the data and felt that there were 7% of savings for CCGs, which is a substantial amount, £21 million per CCG, if this kind of work was put into operation. So we have increasing evidence that this is financially worthwhile as well. Next, please. Now, the concept of social capital is important, and essentially all it means is lots of social connections added up together. So it's the sort of combination of people's relationship with each other, their trust for each other and in each other, and their ability to coordinate and work together. And lots of councils are actually measuring social capital at the moment. I don't think it's universal, and with austerity it may have dramatically reduced over the last few years, but measuring social capital is quite a common occurrence, and we're suggesting as Alliance that this is something that everybody could do. Next slide, please, because there is this measure which is really quite old now and has been validated across the world, many different languages, many different places. And it's a really simple questionnaire. So one way of thinking about this could be that you do a before and after of any intervention, or you can monitor change over time. It's sensitive to change, this particular scale. And as you can see, there are really only 2 questions. I don't actually know how you score it, but we can find that out. It's called Sampson's Collective Efficacy Scale. And could your neighbours be counted on to intervene in various ways? And please rate whether you agree with the following statements, which are really about about mutual trust in an area. And if you were to work in a community strengthening way, we would expect that you could measure it in this way by asking these questions of various communities. Our experience of doing questionnaires is that we think there should at least be 2 components. One is whatever questionnaire the scientists suggest, like this one, but also it's most important that people are encouraged to ask the questions that matter to them as well. So the community has to be in charge of doing the research, and also whatever the data comes out needs to be shared with the community as well. Next slide, please. And that's the end. I hope that's been of help, and I'm sorry it's been so quick, but I hope you find it useful, and there may be an opportunity in the breakout rooms to talk about it if you want to. Thank you very much.
Thank you, Brian. Lovely. Okay, so we're 45 minutes in. I've just noticed Rhiannon McVeigh has joined. I don't think Rachel has from SCW, but Rhiannon has. And I wondered at this stage, Rhiannon, if you would like to say anything, or whether the moment's gone, and whether you would prefer for us to continue.
Thank you I'll make it very brief. So thank you, and apologies I couldn't join for the start, but just to say that, yeah, so for those of you that don't know me, I'm Rhiannon McVeigh, I'm Senior Project Manager, so I work for South, Central and West. So we support behind the scenes of the Connectors programme and try to bring all of the partners together, including the Health Creation Alliance, but also with the ICSs and working with NHS England. So today is a really important part of the wider learning and support programme, in particular thinking about how health creation can be a core feature for each of the connector programs across the country. So I'm really glad that you could all join today, but also for those who haven't been able to join, I hope that you'll be able to watch the recording as well, because I think that this is a really important focus, and the Health Creation Alliance have been a key partner in developing that connector model right from the beginning. And when we think about how those individuals can have impact on the system, decisions, it's about how we work with communities and how recognizing that they already have the answers. It's about how we make that accessible to the system and then NHS. So yeah, really great to be here, and apologies again that I wasn't here at the beginning, Maren.
Not to worry, and thank you for that. At this stage, we've got more to get into as a, and it's going to be a little bit more interactive going forward. But I just wondered at this stage if we would pause for a moment and just give you an opportunity. We've got about 35, I think, on the call, so it's quite a lot, but not too many. But just give you an opportunity to sort of speak up. We've got 5 or 10 minutes maybe to say, does this resonate with you? Are you already doing it, or have you got a mind to do it? Are you interested in working, in your connector program being sort of, focused on health creation, and how are you looking to build this in? So I'm just at the risk of, I hope not putting anyone on the spot, I won't ask for names, but just if anyone wants to say anything. I can't actually see everyone, but do either raise your hand physically or pop a hand into the, pop an electronic hand up if you like. because it would be good to just get some sense of whether this is, you know, making sense to you, or whether it's, here we are, Andrea, yeah.
Hi, thanks for that, and thanks for the presentation. It makes absolute sense. I've not heard anything in the recent days and weeks that's made as much sense, I think, as this. I suppose I feel like in Northern Devon we've come to the same conclusions as you. You know, communities are key, relationships are key, control is key, all of those things. And I suppose I'm sort of surprised. This is all the presentation you're giving today, and the work of, you know, it's the first time I've looked at your website or any of that, and I'm kind of quite shocked. And I suppose I'm looking forward to seeing how we can learn from you and the work that you've done and the frameworks that you've put together, the evidence that you've brought together, because I feel like I think you're going to be a really massive resource for us. So just thank you very much.
Thank you very much for that. It's helpful for us to hear that, actually, because we, you know, sometimes sort of when you get embedded in doing this, you know, you can sort of lose touch with what impact it's really having. So thank you for mentioning that, and I do hope that you know, the way of thinking can be helpful. How I'm starting to think of it recently is that we come from a different perspective, and we have a different paradigm from services generally. So a lot of people are trying to get to this place, but they're trying to do it through a service lens and a service paradigm, and kind of get there in the end. You know, eventually we'll be able to do this. But what we're doing is coming from the community paradigm and saying, this is how it's done. Here's people doing it, and, you know, and sort of putting that different perspective and paradigm on it makes it wholly different. So yeah. Anyone else who has anything to sort of say, or how, you know, anything to do with your connector program? Any resonance there? No, everyone is come to listen today, but that's fine. Okay, well, hopefully there'll be more opportunities in the breakout groups as well, to be able to sort of kick the tires on this and look at how you might be doing this, or how you might adopt and embed health creation going forward. What we're going to do now is look at the 6 features of health creating practices a little bit more and unpack them a little bit. And I'm just going to take you through some of those. And then what we're going to do is to hear from two stories, one from Leicester and one from actually a national program. And we're going to look to see if we can spot some of those health creating practices within that. And later on, we might just give you a few reflections as well from some work we did in the early days of the Core 20+5 Connector program, and just some feedback from connectors themselves about what doesn't work. But if you continue with this presentation, Neil, and pop up 6 features. So just going into these a little bit deeper, because one of the things which we try and encourage people to do is to dig deeper. And not just think of the answers that you often think of when looking at what actually makes a difference for communities, but to dig a bit deeper. So we're going to do that now. So I'll just go through each of these to give a little bit more, so that more people understand them, because some of them are easier to really understand than others. So when it comes to listening and responding, we're talking here about it's quite hard, the responding bit in particular. We find that quite a lot of people, listen effectively, but actually hearing what people are really saying and communicating in a form that is going to sort of bring some of this, enables people to talk about stuff is really important. So genuine listening to the reality of people's and communities' lives, perhaps in a conversational form is often better than through, say, a survey or a questionnaire. And then the difficulty bit is acting differently on what we hear, because sometimes the system doesn't allow you to do that, which is why this has to be a systems transformation. But the listening in itself helps to build trust. Just being listened to and feeling that someone has heard you and has really understood what it is you're trying to say and get that feedback really helps to build rapport with people. And people often say, what is it? How can I build trust with this particular group of people? Well, just listening to them and being prepared to sit and listen and enables people to, to feel safe, to open up more, to tell more, and to say more. So if you want your community's insights, you need to spend a little bit of time and communicate in a way that works for them. And this is the role of connectors is critical in this, because if they're trusted by communities, they already will be, sort of listening. But being listened to can be therapeutic in itself as well. So that's a little bit more about listening and the responding. We know the responding's hard, but it's not always that hard, because sometimes the things that people actually need or would make a big difference, and they tell you make a big difference, are actually sometimes very small and quite easy to offer, and that can make a big difference. We have a thing. I've forgotten. It's not something we invented, but I've forgotten who did. But we call it a Trojan mouse, which is small things that make a big difference, and they can be quite powerful. So coming on to truth telling, this is important. It's the basis for trust building and for respect, and it can be around professionals telling the truth about the services and the systems, about what's possible, about what isn't possible as well. If something is too big and it's just not possible, or perhaps not possible at that time, the feedback about that is really valued by communities, because at least you've told the truth about the fact that although you've listened and you would like to respond, you cannot respond at the present moment because X, Y, Z. That is often understood, and your communities will often want to work with you to try and remove some of those barriers and to change that policy or that system that's holding you back as a professional. Also helping people to feel sufficiently safe to tell their truths is also a healing part of the process. So what is it that holds people back from being well, from creating health? And I hear this over and over again, with support workers. And that is where perhaps through the Community Connector programme, we can start to enable the communities to believe that what they're saying may well, the truths they're telling you may well be dealt with and be addressed and in partnership with them as well. So that can get to the root causes of problems, real truth telling. And that's on both sides, the professionals and the system and the community, some of the issues that communities face there. When it comes to focus on strengths, this is again where the solutions come in often. So people often tell us that they don't have time for this. We haven't got the capacity to do it. We need more people. But actually, you've got a huge capacity and resource within your community. And that's what's exciting about the Connector programme, because connectors are from the community and are part of that resource. So if you can bring some of that into the solutions, work in partnership with them, or in some instances help communities to lead, which is about taking control, then that is going to be part of how you develop this health creating communities. Now, the strength focus is really important, because we paying attention to what it is that people and communities can do, and the strengths within them, or maybe could do if they have built their confidence to be able to believe that this is going to work and believe that they can do things. Sometimes people are not aware of their own strengths. We find this a lot, that people are just they've kind of haven't had the opportunity to use them, so they're not so aware of them anymore. And helping to spot those strengths and develop them is part of their journey to well-being, as well as being part of the solution for their community. So making people aware of their strengths and finding opportunities for them to employ them can unlock that potential and build confidence for creating health. So strength focused, very important. Then we go into self-organizing, and actually some of the work that we did early on in this program, it was very much, we actually talked about what works in community connectors, but what people actually came back and told us was what works in terms of connected communities. And that was how the communities that we talked to interpreted the question. How do community connectors reduce, or connected communities reduce health inequalities? And this is the self-organized piece, because some of the communities we talked to were already self-organized, but they just needed to sort of have that connection with services, and then they could play their part, and they certainly did in the vaccination rollout, and enabled the number of vaccinations to be radically increased from about 30% to about 70%, I think, in one case. So building meaningful connections with others makes it possible, for people to find the solutions collectively. And someone put it here in one of our sessions that, just bear with me a moment, see if I can find the quote here. Linking people together so that they can create collective action and make change as a group. That's what some of your local area coordinators are doing, and community development workers within the places where you are. So actually everyone can start to do that, and the community connectors, I'm sure, will be doing some of that, but it's about finding that sort of collective purpose that drives wellness, and over time does actually reduce reliance on services, because people can find out more information, or run more of those services themselves, actually, in some instances. I can give you some examples of that. I'm going to go to reciprocity next, because this is one we added quite late, which is why we put, it's in the 6th position here, but actually it should really be in 5th position. We added this about a year ago because it kept coming to the surface that unless you have a give-get dynamic, it doesn't really work. So people need to, if they're giving, if they're coming along to meetings and telling you how it is, they need something back for that. They need to know that you're doing something with that information. And similar, perhaps be remunerated. Reciprocity comes in a number of forms. Similarly, if people are getting from a system, if you're receiving services, people often want to give back as part of their self-esteem, and this builds respectful relationships. If you're familiar with the Wigan deal, there's a reason why it's a deal, because Wigan Council did a deal with communities, and there was something for the services to do, something for the communities to do, and here's the result we get as a result. So it's about reciprocity. And we know, for example, that people prefer to go to a community pantry where they pay for food, even if it's inexpensive, than to a food bank where they get it for free. It's something psychological about how important that is. So reciprocity is really important, and that can be built into everything that you do. And I'm sure your connectors will totally identify with all of these, actually, certainly that one. And power shifting and power sharing. So I think sometimes practitioners and the system doesn't understand how much power it has when it comes to people and communities with some of the poorest health outcomes, and helping to shift some of that power, whether that's through training or making information available, or supporting a community space to thrive, perhaps financially, or in all sorts of ways that power shifting and power sharing can happen. So that is that runs throughout all of these. So if we go to the next slide, then what we find over many people that we've talked to over time and places where we've worked, we often find that people are quite good at listening, not so much at responding. Truth telling is there. So current practice, there's not a lot of obfuscating when it comes to communities. There might be people trying to manage expectations. That's one way of kind of not telling the whole truth or not telling everything, but actually it's we don't find that people are, we find there's quite a lot of truth telling. We find there's less focus on the strengths of communities, or less appreciation of how strong communities can be and how much self-led they can be, actually. And so we think there's further to go on that. When it comes to self-organising, we find very little of this. It is the key skill in community development, but we think that it's something that everyone can do a little bit of, and certainly everyone needs to understand, because it's the thing that's going to sustain health creation. So that's the biggest weakness, generally out there, helping communities to self-organise. And we find this power shifting and power sharing quite hard as well. Systems find that quite hard, and to get their head around. Quite often they want to talk to communities and then deliver services to them that the communities are going to use. And it's still that power dynamic of we'll deliver services to you. But actually that needs to completely change. We will work in partnership with you to deliver whatever is required to enable our communities to have good health. And reciprocity, we find, is not really being thought about very much in terms of being built in. So that's the current sort of status. We'd like to see that shift over the coming months and years, and hopefully through the Connector programme as well. And another way of putting this, before we get onto the examples, is to talk about, when it comes to the NHS in particular, if you put the next slide on, we can look at kind of traditional health improvement, or NHS health improvement, which is about, it tends to focus on NHS determined groups or clinical issues by service professionals. So it's smoking cessation. Come along to our work, to our courses, will help you to stop smoking. That's in box 1. Box 2, health improvement, is perhaps, it may be focused on, maybe you talk to affected communities about the issues, but the locus of control is still about what matters to the NHS and the clinical issues that matter to them, and it's by service professionals ultimately. So that's in box 2. In number 3, we see a bit of a shift, because number 3 is being done with partnership, in partnership with communities, and that's a genuine partnership. And we would still call that health improvement, though, because it's still about what matters to the NHS and what NHS determined groups or clinical issues. And actually number 3 is where we have sort of generally said this is roughly where Core20PLUS 5 sits. It's in partnership with communities, but we still wanted to focus on the 5 clinical priorities. There's a reason for that, because the data says that those are the 5 most for the 5 clinical issues which are more prevalent in communities with the poorest health outcomes. However, the biggest shift happens when we start to get into focusing on what matters to communities and what they say is important, which might be, in some circumstances, the same thing as the NHS determined priorities, because often, communities are concerned about things like high levels of diabetes type 2, and that can be one of their priority issues. But let's start to talk to communities about what are their priorities in terms of better health. And that's where you start to get the power shift, which we would then say that tips into health creation. And it's in genuine partnership with communities. And then 5 is where communities are actually taking charge and doing some of this and thinking of ideas and coming up with solutions and then making the solutions happen, supported by the professionals within this. So actually, 4 and 5, we would say that power shift has taken place, and that's what needs to happen. So that hopefully helps you to see where the locus of control sits and where one thing turns into another. All of this is important, by the way, from 2 onwards, I would say. It's important to shift along there, and there's something that needs to go in all the boxes. So it's not that you have to do everything in quadrants 4 and 5. Some of it may well sit in quadrant 3, possibly even 2, but actually we'd like to be a lot more in 4 and 5. So we'd like systems to shift much more into that area. So I'm going to stop there, and we're going to now focus on, unless anyone wants to sort of say anything now, you've realised that I'm going to open it up every now and then for you to reflect and offer some reflections. If anyone has got any things they'd like to say at this stage, or just, you know, is this new? Is it something you've been thinking about for some time? It'd be really great to be able to hear about that. I'll see if there's anything in the chat box.
Harvey has talked about the community having the right to change their minds, and I was wondering what you were thinking of, Harvey, in particular, whether you'd had an experience of that or something.
I knew you were going to ask me that.
Well, you put it in the chat. Since,
well, there were two things that come to mind. One is, you know, talking about putting power back in communities. Is it new? I think that if anyone's been following public health for quite some time, we know that this is something that Sherry Arnstein wrote about back in the 1970s, talking about, you know, the sort of ladder of citizen participation and how, you know, how much control we're giving to individuals. So that's a really old model, a public health model that we sort of know about, but we're sort of coming back around to it, and we have to admit that it's okay that we come back around to it, as long as we come back around to it. Secondly, just in response to your question there, Brian, is really off the back of a leadership conference that I attended about a month ago, where there was a guest, Carolyn Guillory, I think her name was, that came from New Zealand, and was sharing a fantastic model that they used in New Zealand, and how they turned around sort of health outcomes for the Maori people. I think since 2007 or 2008, they started to do things differently. And what they did was they gathered into a room and they did that consultation and co-production. And the final result that came out of that consultation, they presented it back to those communities, and the community went, "No, that's not what we meant. We don't like that." And they had to understand, okay, well, that's fine. Well, let's go back in and let's bring the same people back into the room, whether it was commissioning or clinical services or EDI or health inequality, whatever those people were in the room, bring everybody back in. But this time we're going to give sort of our clinicians and our professionals and public health people, a pencil, to add notes to that. And we're going to give big fat markers and pens to the community members, so that when it was captured, the voices were visibly more pronounced in the community members. I thought it was a really fantastic example of how they watch differently to hear back from the community and say, actually, it didn't work in the first round. What do we now feel about this? And then to roll with that change and that shift in perspective, which is a natural part of that journey, I think. So that's what I meant. Yeah.
Thank you. If there's anything written up about that, I'd be interested to see it. As I said, I'm writing this literature review, so it's all grist to my mill. If you've got any papers or anything about that, that would be very handy.
Thank you. And I think that actually is a good reminder to say that it's okay to try something and not get it right first time, and then reflect on what you might do differently. And we had a really good example of that at our latest sessions, coming of age sessions, where a GP did say, we tried X, Y, Z, and it didn't work, and I had to, I was quite crestfallen. I had to go and have a think about that, and I realised that actually it's not all about me, it's about those people. And so then he sort of got his head into the community paradigm more and reworked it, and it worked. And I think that was it's brilliant that he felt able to share that, because it's not easy for people to share failure as such, but it's all part of this process of getting our head in the community paradigm. And it's absolutely fine to not succeed initially. Obviously better to succeed initially, but it's fine not to. Neil, do you want to go on to the next stage then on the Leicester and
certainly.
Yep.
Okay.
Good morning, everybody. It's great to be here and hear some wonderful things about the Core20PLUS programme. I'm one of the delivery partners in Leicestershire and Rutland ICS, delivering the Core20 Connectors programme. So can I have the first slide, please? The next slide, yeah. Well, the focus of our programme is about improving engagement and contribution to reducing health inequalities in some of the most deprived Black, Asian, minority ethnic communities in Leicester, Leicestershire and Rutland. And we focus on 3 areas. We know we can't do everything, but 3 key clinical areas: cancer, hypertension and respiratory COPD. There's 3 delivery partners: Shamma Women's Centre, Equality Action and SAHA. Shamma Women's Centre, we've been around for 37 years, and some of the departments basically deprived areas in Leicester City. And we've had experience of empowering Black, Asian, minority women in Leicester in many areas of education, including health inequalities and closing the gap. The women that we're dealing with in this programme have multiple barriers. They have cultural barriers, language barriers, poor literacy skills, lack of understanding in particular in terms of health education. But there's also other socio-determinants of health, factors such as poor diet, exercise and smoking, which play a really important part. Next slide, please, Neil. So for us, the community connectors have a very important role in providing that kind of interface and contact. But the contact for our connectors to be meaningful, we've recruited a programme coordinator with a lived experience, multilingual lady, and we plan to recruit 10 connectors throughout the programme, but we've recruited 6 connectors with lived experience across the 3 clinical areas. But very importantly, what we look for was the passion and the motivation for these individuals to want to create an impact and to make a difference in their community in terms of health outcomes. And that's a very important ingredient. But to enable them to do that, to have the confidence to turn that into something positive, we've got to make sure that we have the kind of training and support and knowledge they need to do that. We already had an initial development session, which is co-produced by NHS colleagues. And I must stress, we are one team, and that's really important, working at as one team, and the connectors see us as one team. And we use that session to identify skills and gaps and support they needed. Now, this was actually going to feed into a training and development programme with it's a collaboration workshop on the 1st of November with our clinical needs. But very importantly, I think it was important to get feedback from our connectors in terms of what they felt they needed to do the job, not to sit and just devise a programme thinking we think this is best for them. But in terms of lived experience, in terms of what impact they've made on themselves and on their community. But one of the things that, in terms of my role, I've learned, and as a community leader, is that by giving the only way you can give control to the community, and this is reflected in Health Creation's principles, is about empowering women in health education, and they want to learn, they just want that opportunity, and providing them with the knowledge of how to access NHS and other support services and bringing those NH services close to them. And we've done that through running a series of awareness events, and they've been very, very successful. But also what we aim to do, and we'll continue to, is provide insight. It's about addressing enablers. What would it take for you to go for your smear test? And I want to kind of illustrate Health Creation in a real life kind of example. Next slide, please, Neil. Talent, she's used her personal experience avoiding having her cervical smears for over 7 years, and she identified it was basically because she didn't want to remove underwear, and this resonated with many Black, Asian, minority ethnic women that she spoke to. So she actually did something positive. She produced some lingerie designed for clinical examination, where you don't have to actually remove your underwear. There's poppers there, and this kind of gave the strength and focus. And so she produced these, test marketed them, and then provided samples to a local GP. And the important thing is a local GP actually listened to what their barriers were, listened and responded, and that GP's actually improved an uptake in terms of kind of women taking smears. But very importantly, she also wants to use this passion to continue and work as a connector. And I think for her, the highlight was when one of her friends had a smear test as a result of this underwear, and detected very early on for cervical cancer. So it's about empowering communities, listening to communities and acting upon them. Next slide, please, Neil. Well, for us, health creations has to be co-production. We have to be one team. It's a joint-up approach to meeting health inequalities, and it's got to be driven by the community. It won't work otherwise. And working with our clinical leads, for example, our long COVID lead, there's areas, you know, the communities don't even understand, Black Asian minority communities, that they've got long COVID. So again, we're going to use that insight from that to feed that programme. For us, connectors are going to be a vital interface and have been between PCN, social prescribers, and also faith and community groups. The community needs to know who to go to, where to go, and why, you know, what is the impact if they don't go for their smear test. But very importantly, our connectors will be providing insight. We're looking at quality, not quantity. It's that little gem that could change somebody's life, like those pop-up pants. But I think to keep that confidence of the community and keep them engaged, and is recognition of input from people and those communities. It is a slow burner, it will take time, but it's about building up trust and creating that sustainability.
I can do that. Thank you very much for having me, and thank you very much for inviting me to be part of this. I feel very inspired around, you know, the health creation and those principles that you've put forward. We were this year the winners of the Creating Community Connector Award for the Health Creation Awards, and that really helped us, I think, as an organisation, through our future planning, really frame our thinking around those 6 features that you talk about, and helped us as an organisation, you know, knowing that that's the work that we are doing, but now being able to see it in action and to be able to explain it in a way that's really accessible, and people can kind of grab onto. So yeah, very grateful to be here. I'm Emily Abbott, the Programme Director for Intergenerational Music Making. You can pop onto the next slide, please, Neil. Wonderful. So I just wanted to give you a rundown of who we are as an organisation, and a little bit about our programmes, and how we adopt and really kind of try and implement that health creation approach to all of the work that we do. So Intergenerational Music Making is leading an intergenerational organisation. We are UK wide, and we have been delivering projects, training and research since 2018. The idea is the work that we do, we use music as the vehicle into social connection, and we do it in an intergenerational way. So with the aim to bridge the gap between different generations, to tackle isolation and loneliness, to improve the lives of those living with dementia, improve mental health for both the older and the younger generation, and really create stronger and more cohesive communities. And through our research, we have kind of identified 5 key aspects to what is working and what is important in the work that we do. And that is bringing together people to share meaningful experiences, creating an enabling and equal status interaction, so a mutually experienced value between people from different walks of life and different generations, nurturing people's agency to improve their own life, so being an advocate for their own health and positioning ourselves around that individual so that we can best respond to, you know, our ever evolving and changing needs, cultivating a sense of belonging within and to a specific place, and that having a direct impact on how we see the world and how we want to respond to our community, and empowering individuals through training and the transference of knowledge and skills and capability, and the empowerment and the training are kind of our fundamentals to that future health creation and embedding the practice across the different sectors. Next slide, please. So we have 3 specific pillars to the work that we do, and that is our programmes, which I'll go on to talk a little bit about. And all of our programmes are co-produced with communities. So we have groups and staff members that align themselves across the UK and work directly with individuals and communities to understand needs and to acknowledge approaches and capacity and how people view the world, and then to shape services to meet those needs. And so our programs use music as that vehicle, as I said, but they're adapted and tailored and bespoke to meet those individual groups. We then have our training, which is rooted in empowering and creating sort of a cohort of change makers and activators at a grassroots level, so providing them with the knowledge and understanding of, if I use music in this specific way, how can I have a direct impact on somebody's health and well-being and a long-term, you know, benefit to our wider community and collective well-being. And that also comes in using music as that vehicle into connection and community, not only bridging the gap between generations, but also sectors and professionals, and really enhancing that cross-sectorial partnership working through music and intergenerational practice. And then also our research, which is a primary arm of the work that we do. And our research partner is the London South Bank. And we work to really kind of unpick the mechanisms within intergenerational practice and intergenerational music, and understand what it is about our approach that has the ability to kind of sit at the heart of our ecosystem. The work that we do, obviously you have the intergenerational, which as we see it encompasses people from different backgrounds, different sectors. We're working across the ecosystem. And then you have music, which is our vehicle, which both scientifically and anecdotally is this universal language that everyone has the ability to connect with, to resonate with, you know, a kind of a conduit into self-reflection, connection. And so when you bring those two things together, having a language and a medium that encompasses everyone, we see that as having a real potential of responding and amplifying voices of people from across our sectors. Next slide, please. So this is the programme that we were awarded the Connector Award for. So back in 2019, at the start of the pandemic, we were working a lot within communities, and we carried out 42 think tank and consultation sessions with communities across the UK. And that was really for us to kind of understand the different levels of need, and understanding that, you know, COVID was impacting everyone in very different ways, and how the landscape continued to change and evolve, and how we could, you know, use our team and our expertise to change and evolve with it. So the idea was connecting people, voices with lived experience, and young people, bringing together children and professionals from across care and education, and creating these spaces to invite conversation and invite people to challenge, you know, the ideals of what should be or what we were seeing, and help shape a response that was better suited to what they needed. So we had our what we found is that because of that personalized approach, we needed a team that was able to kind of nurture that and be on the ground to continue supporting those connections. And so we had our regional connectors that we implemented across the UK, and they worked encouraging groups across sectors to be part of Together with Music, which was the program that we launched. And what this was a digital online program to help encourage new connections, maintain existing connections, to create spaces whereby people could exchange resources, share best practice, connect with people both on a local level but also on a national level. And how we managed that connection was through a musical exchange. So everything started with a song. The reason for that was understanding that everyone has a song that is personal to them, you know, a song that is rooted in who you are, your identity, your culture, your history. And just through that sharing of a song opens up this incredible new conversation that, you know, is rooted in that individual and provides them with a space to, you know, ignite and celebrate who they are. And so what we were kind of seeing across is care home residents sharing songs that were important to them, that took them back to a specific place in time, and sharing their stories and their experiences with children from schools, and university students being part of that exchange, and care staff. And actually through that musical exchange, people understand, I think all of us throughout COVID, understanding one, the place that music has within our individual well-being. You know, it's everywhere you go. You hear it on when you're shopping in the supermarket. You all have that kind of, I'm sure if there was a moment and you had a song that was personal to you and helped you if you were feeling low, or just you couldn't help but dance to it. Everyone has that innate connection to music and to an experience. And what we were finding was that, you know, music was becoming that key pillar, but also we were understanding the importance of social connection, and how fundamental social connection was to our well-being. You know, how we live and how we flourish as individuals is so rooted in our relationships, and not just, you know, knowing people, but having meaningful interactions and meaningful connections. And this is what we were able to do through the site, and through having those very localized connectors on the ground, working with groups to understand what they needed and how best we could help support them during this time. And just to kind of, that also came from digital training, so partnering with Barclays Digital Eagles to provide digital training so that people could get connected, understanding, you know, if people didn't have Wi-Fi's or equipment or you know, musical Spotify accounts, like how could we keep these connections going, and what could we do? So we were sending memory sticks out, we were you know, kind of shaping our support to make sure that we were fitting into what they had and their capacities. And then as we came out of COVID, we continued to have those consultations and to hold our steering groups, and it became very apparent, and I'm sure for everyone, that in-person social connection was the next step, and we needed to find very innovative and safe ways of bringing people back together. So we delivered a lot of outdoor sessions. There were some projects, and there's a video that I would love to show you that will pop in the chat in case Neil can share it with you. But we were finding that we needed to find ways that we could bring groups that get back together, and that was a core part of the work that we did, and kind of rooted in that, and as part of that delivery was implementing this very interactive and hands-on training to empower care staff and teachers and local volunteers to help embed the practices. So, you know, we can go in and deliver a project and connect those two generations, whether it be a school and a care home, but how do we keep it going so that that school doesn't just come in at Christmas and wave outside the window, but you know, we can support in an exchange whereby potentially an older person becomes a homework buddy, or you know, comes in and helps teach. You know, there was one case study where there was a group of children, they were kind of neighbours, so when you went into the care home garden you could see over the fence and that was the school, but they had no sort of interaction and no sort of connection, and so they signed up Together with Music, and this was the case study that we actually I wanted to show you, but they signed up Together with Music, and we were able to work with both the school to identify those individuals across both the settings that had been most impacted by COVID. So whether they're children that had lost confidence or withdrawn in the classroom, residents who had been isolated, and again had just were showing signs of anxiety and depression from not having that social connection. And so these individuals were specifically referred in and having, you know, a real need in accessing this work. And we delivered a 6-week project whereby the residents would sit inside and we would open the double doors and the children would be outside of the care home. And what was beautiful is that through the medium of songwriting, which is a medium that we use a lot, we were able to create a space where learning and capturing of data took place, but in such a beautiful and creative way. So by taking the lyrics of My Favorite Things or Happy by Pharrell Williams, and asking people very simply, what is it in life that makes you happy? Or what are some of your favorite things to do or favorite places to be? And having that exchange across generations, and then for us as facilitators to be able to capture that data, so many things we were able to take from that to kind of assist in our learning. And what was wonderful is it just continued to solidify that connection across generations, you know, with people realizing that there was mutual loves for cups of tea and walks in the forest and fresh air and pizza by the sea. So all of these things that kind of created this mutual connection between people, but also in a really creative way, it opened us up to being able to continue to learn and develop, you know, capture learning and be able to develop our programs from that. And for that project, we also were able to demonstrate really strong partnership working across the sectors. So we worked with the Surrey Downs CCG group, the council, the care home and the school. And through that project, as a pilot of Together with Music and how we could then roll it out across Surrey Downs, it was a really wonderful demonstration of how intergenerational music can also support in that partnership working, that integrated care pathway, supporting people from community to care home, and across those sectors. So hopefully we can send out the video after this.
Should we try the video, Emily? Is this?
There's never been a greater need for social connection, particularly at either end of the age spectrum.
COVID has absolutely accelerated the disconnect between care homes and their community.
They haven't been allowed to have visitors, or it's been very limited, maybe people standing outside the window. There hasn't been much human contact.
We're absolutely delighted to collaborate with IMM Music and NHS Surrey Downs ICP to bring music to young and old for mutual benefit here in Bookham.
Today has been our last session of a 6-week block of intergenerational music making sessions, and we've been working with 6 kids from the primary school and 6 elders from the care home, and these places are right next to each other. We are literally in the garden right now, and over the fence I can see the children's playground.
Hello, hello, welcome to our music time, and we hope you're feeling fine.
The aim of our sessions is connection, and we use music to get that connection.
The 2 different groups were singing together, conducting, playing musical instruments.
Creating this really safe, positive space for them to explore who they are and what's important to them. Marion did something really wonderful with Happy, a tune that we all know and love and makes us feel good, and asked the children and the residents very basically, what is it in life that makes you happy?
And what was wonderful was we found all these things that made both of the groups happy.
There was cups of tea and animals and dancing and singing.
If you feel like dancing's what you wanna do.
Woo! The children were so touched when one of the big things that came out of our discussion was that the elders said seeing the children happy made them happy.
They just love listening to the children. They love seeing them smile. They love hearing the music, hearing the stories.
We're so pleased that they'll come and entertain us, because that's what we need.
Yes.
It makes a lot of difference to us.
A lot of people assume that what we're doing is just for the old people, but it's not. What we're doing actually really benefits the children we work with. We get a lot of referrals with children who have additional needs, or they might be anxious, they may have had a really hard time the last year.
I think it's so empowering for them to be able to just stand and share who they are, and to have that positive feedback.
I feel like I know the elders a lot more, and now I know what they like and what style of music they like.
Our hope is that now that connection has initially been made, that Eastwick School and Keswick Care Home can build on that.
I think we will see reduced calls upon health interventions and maybe even sort of medication, because someone's well-being, their whole sense of purpose and happiness, we know affects their physical health substantially.
The final outcome of where I'd like to take this is, at the very least, I'd like to see this across Surrey Downs, and maybe I'd like us to be looking at this in other areas rather than just care homes. How else can we focus a bit more holistically about how to improve our residents' lives to get the health outcomes that we want, rather than waiting for someone to fall over and then we put a plaster on it? Let's try and improve their lives so that they don't fall over in the first place. Let's take a step back and do all sorts of other things that we can do to make their lives and their community even better.
And hopefully for everyone that kind of brought to life a little bit about what I was saying, seeing how intergenerational music has that ability to support those generations, but also to promote and really nurture cross-sectorial relationships. And Sarah, it's lovely to hear that it made you cry. I also get very emotional every time I see it. I wonder, Neil, if we can pop the presentation back on. Thank you all for being patient. I know that the tech doesn't always go our way. Just the slide with the
which slide would you like on?
54, please.
Okay.
Brilliant. Thank you very much. So this is just a
no, this one.
Back one.
Sorry, step.
Yes.
There we are. Okay.
Perfect. Thank you very much. So this is just a diagram that we kind of visually wanted to represent, basically looking at intergenerational music and that mechanism sitting right at the heart of our ecosystems, which at IMM, we really believe that it has that ability to sit right at the heart of those ecosystems, because as I mentioned, we are working across social care and education, and the arts, and also health. So encompassing people from across generations, across backgrounds, a range of pathologies, and then through the music and that connection. Sorry, I've lost you. Music and that connection, we are then kind of having that ripple effect and supporting in training and employment, health and wellbeing, sitting across social prescribing, partnership working, health inequalities, and also research. What we find is that through intergenerational activities and that social engagement, we're able to really build on the strengths of different that the different generations have to offer, and nurture understanding and mutual respect, whilst also challenging ageism and stigmas around age, both young and old. We know from experience that music can connect and transcend across age and background, and specifically in generational music, having that ability to sit at the heart of the ecosystems and respond to healthcare, job, employment. So that's something we're kind of striving to advocate for across the sectors and across our delivery. Can I have the next slide?
Fantastic.
Please?
Emily, I'm just sorry, I'm just very conscious of the time. And actually we would like to work with all the participants to reflect on what you shared. So are you okay to just sort of round up there so we can then move on? We were going to have a breakout group, which we probably won't have, but we do need to be able to get everyone to reflect on what you've said.
Of course, yeah, I think that's probably a good place to end.